things to cover today. One is Stridor, one is Laryngotracheobronchitis, commonly known as croup, viral croup. One is acute epiglottitis, and one will come later, that is foreign body aspiration. Now, just what you have seen on video was a video of Stridor, a little baby. The other video they could not receive was a similar looking baby, but healthy baby having the same features. So, what is Stridor first? What is Stridor? Next slide. আচ্ছা এটা দিয়ে করা যাবে তো? এই দেখ এই দুটো লিঙ্ক ছিল, তলার এই যে লিঙ্কটা এটা ছিল তোমার ওই হেলদি চাইল্ডের জন্য, ছেড়ে দাও। ওকে, এটা নেমে গেছে নিচে, দেখবে নেমে না যায় যেন। Now what is Stridor? Stridor, just look at the definition. It is a high or low pitched audible, it was audible, harsh respiratory sound. It is high or low pitched. Why? Because the lesser the caliber of the airway, the higher will be the pitch. Like when you see, when you examine the chest of a bronchial asthma patient, you listen to rhonchi because the airways are much smaller there and the sounds are much more musical and much more low pitched. But for Stridor, because it is coming from the upper airways, they are coming from the bigger airways, larger airways. So the sound is harsh and this is low pitched. So it's a high or low pitched audible harsh respiratory sound due to rapid turbulent airflow. Normal airflow through the lungs, through the airways should be streamline airflow, not turbulent. Whenever there is obstruction, the airflow becomes turbulent and the noise is generated. Through a partially obstructed large upper airway. Upper airways are larger and when they are partially obstructed, when they are fully obstructed, there is no sound. When they are partially obstructed, you get the sound. Okay? And the more they are obstructed, the smaller the caliber becomes, the higher the pitch becomes and lesser the intensity becomes. And that is usually taken as an ominous sign because the airway is getting more and more obstructed. Usually Stridor is inspiratory, but sometimes you get both inspiratory and expiratory, that is biphasic Stridor. The lower the obstruction is along the airway, the lower is the obstruction, the more is the chances that it will become a biphasic. Now look at this. And look at the, the diagram I have made, although very sketchy, but I think you can watch from where you are sitting, the full picture. This is trachea, this is larynx, this part is trachea, these are the bronchi, this is the extrathoracic part of the airway, this is the intrathoracic part of the airway, and this is the junction between the larynx and the trachea, right? Now look there. This obstruction is there in the extrathoracic airway. This is in the extrathoracic airway. And what's happening? Whenever the child is taking inspiration, then what's happening? The rib cage is expanding outward and he is trying to pull air inside, but there is obstruction. So there is negative pressure there. Now, the atmospheric pressure is there outside, just outside the trachea. So what will happen? They are positive and they are negative. So the airway will shrink, will collapse. And that is how Stridor develops. Now during expiration, what happens? During expiration, the lung is trying to push the air out. So, and it is greater than the outer atmospheric pressure. So what happens? The airway once again becomes normal. So during inspiration, the airway is collapsing. During expiration, the airway is becoming normal. That is for the extrathoracic part of the airway. Now what happens to the intrathoracic part? Whenever the child is taking inspiration, then what happens? The lung is expanding, the air is there, it's pulled inside, but the lesion is there, the obstruction is there in the intrathoracic, in the intrapulmonary airways. So what happens? Negative pressure is generated there. See, this is happening during inspiration, right? So negative pressure is there generated, but what's happening? Lung is already pulling the airways out. The lung parenchyma is pulling the airways out. So what happens? There is no collapse. The air just normally is pushed in, is pulled in. But during expiration, what happens? The child is trying to push air through the narrow airway. So there the positive pressure is generated. So the intrathoracic pressure is being positive, but air cannot come here. Air cannot come from here to here, but there is positive pressure. So what will happen? This part of the airway, mind you, this will collapse. And that is how rhonchi or wheeze are generated in the intrathoracic type of obstruction, obstructive airway disorder. Okay. So you understood all this much? That is clear? Now look at the anatomy of the larynx once again, Priyanka. উপরের দিকটা নেই, নিচের দিকটা নেই। আমি জানি না এই ক্লাসের কি তোমাদের কতটা গুরুত্ব তোমাদের কাছে, আমার কাছে তো খুব গুরুত্বপূর্ণ, বাট তোমাদের কাছে আই ডোন্ট নো। মেল তোমরা রিসিভ করোনি, দ্যাট ইজ প্রিটি ব্যাড। বেশ, so this is the anatomy of the larynx. There are 4 types of cartilages in larynx. Probably you can remember from your anatomy lessons. One is the epiglottis, 2 very small cartilages, cuneiform and corniculate cartilages on the posterior wall of the larynx. One arytenoid cartilage is there, triangular in shape, and this is the thyroid cartilage, and this is the cricoid cartilage. So 5 cartilages altogether are there. Of them, only the cricoid cartilage encircles the whole of the larynx from posterior to anterior. It's a continuous encirclement by a cartilage. Now from the epiglottis, there are 2 folds on the both sides of the larynx. There are 2 folds, that is called aryepiglottic fold from the arytenoid cartilage to the epiglottis. And down there you can find 2 more folds. One is the vestibular fold, which is the upper one, and one is the vocal fold, which is the lower one. The function of the vestibular fold is to control the airflow, and the function of vocal fold, you know, whenever you get a hoarseness of voice, whenever you get upper respiratory infection, you jolly well know what the vocal fold does, or what the vocal cords do. Okay. Now for children, the funny thing is that, or I should not say the funny thing, but the peculiar thing is that the most constricted part of the airway is at the level of the cricoid cartilage. This level is the most constricted. For adults, it's near the vocal fold. Now, at the vocal fold, the larynx is surrounded by the thyroid cartilage, which is not a continuous cartilage. The thyroid cartilage opens in the posterior, you know that. So what happens, because this is the cricoid cartilage and this is the complete encirclement of the larynx, as well as this is the most constricted part, the narrowest part of an infant or a child's upper airway. So what happens, even slight amount of edema will cause severe obstruction at this level, because there is no way out. You cannot go outside. It's completely encircled by the cricoid cartilage, and even after that there is edema. There are 1 or 2 more causes that the a child or an infant is more prone to get upper respiratory obstruction. One is, of course, the softness of the cartilage. One is the upper position of the larynx. In cases of infants, the whole larynx is positioned upward, more upward than the adults. That's why they get obstruction very severely and very quickly. So this is the anatomy of the larynx. You should remember. Then this is how it looks in the lateral X-ray. How it looks in the lateral X-ray and lateral MRI. See, this is the epiglottic fold. This is the epiglottis, epiglottic cartilage. And you can see it from the X-ray also. And this is the hyoid bone. The peculiar thing is that hyoid in lateral X-ray seems to point towards the epiglottis. And from there, the larynx has become, and from there, the trachea has become. You have to remember the normal anatomy of the upper airway when you see a lateral X-ray of the neck, because in my later slides, you will find some pathological slides also, some pathological X-rays also. And you can compare this with that, then you know what's happening. Okay. So definition you know. Now clinical features of stridor, you have seen in the video what's happening there. It can be acute or chronic. Acute means usually up to 3 days it is called acute, and chronic means few days, starting from few days to weeks together. It can be chronic, it can be recurrent, like in Laryngomalacia in a child, there is recurrent stridor up to the age of say 9 or 10 months, then it goes away. It can be associated with respiratory distress. It is often associated with coryza and cough, and it's often associated with suprasternal suction, usually associated with suprasternal suction, as we have seen in the video. Now, when mild, its intensity is very loud, or it may be medium intensity. The pitch is low, and it is inspiratory. In cases of moderate stridor, we get softer sound because less air is going in. So, this is softer sound, and this is higher pitched. The lesser the caliber is becoming, the higher becoming the pitch. It can be biphasic. And if it is a severe stridor, then it is barely audible. So reduction of intensity usually indicates increasing in the obstruction of the airway. Remember that. Now these are causes of acute stridor. One thing about stridor, I should have told you in the beginning that stridor is a sign. It's not a disease. It's a sign. So clinical features of stridor, when I will tell you, it will be superimposed by the causes, like some feature in peritonsillar abscess, some feature in retropharyngeal abscess. They are different. Along with that, you get all the clinical features I told you. Okay, understood? Let us see. We start from above downwards. First, around the tonsil, there is the peritonsillar abscess, retropharyngeal abscess behind the pharynx, acute epiglottitis. You come down, you get the epiglottis. Anaphylaxis, that's a disease of the larynx. Acute laryngotracheobronchitis, when the larynx as well as the trachea as well as the bronchi are involved. I shall discuss in detail later. Acute spasmodic laryngitis, acute laryngeal diphtheria, tetany due to hypocalcemia, acute bacterial tracheitis down there, and foreign body aspiration can happen at any stage, at any of the levels. These are the causes of acute stridor. Then chronic stridor, it can be laryngomalacia, it can be vocal cord dysfunction, maybe post-surgical. Subglottic stenosis, which can be congenital or can be acquired. Post-intubation subglottic stenosis is common. Laryngeal cyst or hemangioma or papilloma. Anything in the larynx, any space-occupying lesion in the larynx will cause stridor. Craniofacial anomaly like Pierre-Robin syndrome, you just, when you go to your hostel, you look at the book, you get a picture, there is, the mandible is short, the tongue is falling back, as well as there is stridor because of the weakness of the laryngeal cartilages. That is Pierre-Robin syndrome, and there are many other craniofacial anomalies which are associated with the problems of the larynx, that is stridor. Okay. Any mediastinal mass down there, if it is there, this is the mediastinum, you know. So if there is a mass, suppose there is a lymphoma, enlarged lymph nodes, and that is pressing upon the trachea, then it will cause stridor. আবার নেমে গেছে, উপরেরটা দেখা যাচ্ছে না, নিচেরটা পাচ্ছ তো, উপরটা পাচ্ছ না, এটা কি হচ্ছে? তো সেটা তোমাদের সেটা দেখা উচিত, আমি তো তোমাদের ইমেল পাঠিয়েছিলাম। সো ম্যানেজমেন্ট অফ স্ট্রাইডর অ্যালগোরিদম একটু তুলে রাখো, উপরে ওপর দিকে তুলে রাখো। Now patient with stridor comes. You first take the history. First of all, you have to know what are the causes, what are the possible causes. Then you take the history, do the physical examination, and you can differentiate between the causes. Now, first you assess the pattern, whether it is acute or it is chronic. Algorithm means you can calm down the, one after another, you know what next to do, that is called algorithm. So, first you take the history, then physical examination. At the same time, you assess the pattern, whether this is acute stridor or this is chronic or recurrent stridor. In cases of acute stridor, it is an emergency. You have to do everything in a hurry. Now, in acute stridor, first of all, you assess the degree of respiratory distress, whether it is mild or moderate, or whether this is severe, or whether this is very severe, near about respiratory failure. Let us see. These are how you assess the severity. One is the relation of the stridor to activity. How it is related to activity. Is it happening only during when the child is vigorous and usually is absent when the child is quiet, or it is happening all along? So this is the first thing, relation to activity. Chest air entry. You put your stethoscope on the chest and you know whether the normal vesicular breath sound is coming, what is its intensity, whether there is any shortage of breath sound anywhere on the chest. Then relation of the intensity of the stridor to chest retractions. That means more retraction, less stridor. That means severe obstruction. Less retraction, more stridor. The obstruction is not so severe. Okay. Dehydration. Suppose the child has not taken anything during the last 1 or 2 days. He is having the stridor, he is having the croup, respiratory distress. So the dehydration will give you the clue. Oral intake, whether the child is prepared, whether the child can take anything orally. So respiratory distress increases, oral intake will decrease. Higher function, whether the child is normal, playful. I should have shown you the second slide, they don't have it right now. The Laryngomalacia case, the child is absolutely active and anything like a normal child, only he is having stridor. So, higher function. If the child is agitated or if the child is lethargic, then you know he is on the verge of respiratory failure. And oxygen saturation. Through, pulse oximetry you can do or ABG estimation you can do. There is for assessment of severity, we do the Westley Croup Score. Westley Croup Score. There are 1, 2, 3, 4, 5 points, and every point, every item, every aspect have got few points. Stridor, if there is no stridor, give 0. Only with agitation, give 1, and even at rest, give 2. Retraction, none, give 0. Then 1 with mild restriction, retraction, 2 with moderate retraction, and 3 with severe retraction. Cyanosis, either there is no cyanosis or there is cyanosis with agitation, that gives 4 points, and cyanosis even at rest, that gives 5 points. Now, cyanosis is such a thing that even if it is present anyhow, with agitation maybe, that gives a huge difference between 0 and 4. Consciousness, 0 is for normal, including the child may be asleep or it can be disoriented, you give 5 points. And air entry, 0 for normal, 1 for decreased air entry, and 2 for markedly decreased air entry. Now you add up the points and you get the total. Total maximum points can be scored is 17, 17. Now 0, 1 or 2, that gives you a picture of mild croup. 3, 4 or 5, it's moderate. 6 to 11, that is severe, and anything 12 or above, that gives you impending respiratory failure. So that is a very useful Westley scoring system. Now you have identified the stridor, you have identified identified this is acute stridor. In case of chronic stridor, you can wait, you can send to otolaryngologist, or you can do laryngoscopy later on. But for acute stridor, you have to act immediately. First, you have seen whether this is mild or moderate or severe or very severe stridor, you have classified. Now you identify whether there is impending respiratory failure. For that, you have to act quickly, do intubation, do ventilation, and for angioedema, angioedema can be due to allergy, and you have to give proper medication for allergy. For foreign body, tonsillitis, any abscess like peritonsillar or retropharyngeal, epiglottitis and diphtheria. All those things you have to identify because they have got their own separate treatment protocols. So, you have identified. In the meantime, you have given moist oxygen inhalation if in distress, and remember, there should be no irritation. Some children, they get irritated by seeing the oxygen mask. If you put them on their mask, they become more irritated. Any kind of irritation will cause deterioration in cases of stridor. Particularly in case of acute epiglottitis, it can cause laryngospasm and immediate death. So remember, you give oxygen, no doubt, but don't irritate the child. You can do it by blow-by method. The oxygen flow will be directed to the child, but from a distance. That's a separate topic. There's no time to discuss it right now. Consideration of corticosteroids, it can be given per oral or intramuscular or intravenous. Most of the cases of stridor, they need corticosteroid and epinephrine nebulizer. I think apart from foreign body aspiration, most of the cases they need corticosteroids and epinephrine nebulizer. So you can consider the dose we shall see later on. For mild, you give epinephrine once, twice or even thrice, and after that if the child improves, wait for 3 hours. And then you can discharge the mild cases of stridor. Usually it can be taken as a case of viral Laryngomalacia are commonly known as viral croup. They are usually mild cases and they can be managed at home. Next, if it is moderate or severe, then what you do? First of all, you hospitalize and consider ICU admission, intensive care unit, PICU or NICU admission. Then you visualize the epiglottis. While visualizing epiglottis, you remember that this simple procedure can bring death to the child. So, you keep your intubation team ready. Go to ICU, keep your intubation team, your tracheostomy set ready. If there is any increase in distress, then you have to do immediate intubation, or if there is severe laryngospasm, you have to do their tracheostomy. You have heard about tracheostomy? Okay. Now, if it is normal epiglottis, what are the things you were thinking about? One is bacterial tracheitis, and then what you see, the thick pus is coming out, then culture the tracheal secretion. Even then you can consider intubation if the obstruction is severe. You think about giving IV antibiotic and epinephrine nebulization. Now, normal epiglottis, number 2, consider the commonest thing, viral Laryngotracheobronchitis. Then corticosteroids and epinephrine nebulization, we shall see the doses later on. And if there is response, you can consider discharge. And if there is no response, think about doing a chest X-ray to see whether there is any intrapulmonary pathology or not. Then reassess, and if the child deteriorates, you consider intubation. Now, if it is a swollen and red epiglottis, what is it? It is an epiglottitis. Then controlled intubation, tracheostomy if necessary, chest X-ray to see whether there is pneumonia or not, blood culture, IV antibiotics, and there also you can consider corticosteroid, but prior to intubation to reduce the edema. Okay. And along with that, you also identify any foreign body oropharyngeal mass, laryngotracheal stridor, any other cause, any laryngotracheal disorder, and you can consult your otolaryngologist and pulmonologist. For chronic or recurrent stridor, you have to do laryngoscopy, and you can refer to a otolaryngologist. Now, what are the red flags in a stridor? One is the altered level of consciousness, either agitation or drowsiness. There is excessive work of breathing like diaphoresis, excessive sweating, or increasing retractions. These are the excessive works of breathing. Increasing retractions will lessening noise. The work of breathing is increasing, the noise is decreasing. That means the obstruction is becoming more serious. There is fatigue in the child, or there is impaired perfusion, signs of shock. These are the red flags. You should consider intubation at once. Now we shall discuss all those cases. We shall start from peritonsillar abscess, retropharyngeal abscess, anaphylaxis, laryngeal diphtheria, then acute bacterial tracheitis, then acute epiglottitis and croup. They are separate subjects given to me. They are important for your exam also, and ultimately Laryngomalacia. So let us see one by one. Look at the picture there. The uvula is there. The uvula is displaced to one side. This is a throat picture, of course, you can understand that. This is the tongue depressor, metallic tongue depressor given. Up to this is the tongue depressor. You can follow the picture? You can follow the picture? This is the tongue depressor, this is the uvula, this is the posterior wall of the pharynx seen through the tonsillar pillars. These are the tonsillar pillars. On the right side of the patient, you can see there is a huge swelling which is pushed to the other side. That is a peritonsillar abscess. Usually the age is pre-adolescent or adolescent and starts as a complication of acute tonsillitis. There are added severe symptoms along with the symptoms of tonsillitis. There are added things like high fever and very severe sore throat, dysphagia, the child cannot swallow anything. There is neck pain and cervical lymphadenopathy usually is present. Trismus, that means the child cannot open the jaw. There is spasm of the masseter muscle. Tonsils are enlarged and congested, as you can see, and uvula is edematous and pushed to the opposite side. This is peritonsillar abscess. Now for retropharyngeal abscess, you look at this picture. This is the uvula. This is the uvula, though not very clear, but I think you can make out. This is the uvula. This is the right tonsillar pillar. There is the left tonsillar pillar. The uvula is more or less in the midline. And what's happening in the posterior pharyngeal wall, you can see a swelling. Okay, got it? Okay, so this is retropharyngeal abscess. The age range is less than 6 years because that usually starts with the infection of the lymph nodes there in the retropharyngeal lymph nodes. In this age group, that is below 6 years, up to 6, 7, 8 years, there is abundance of lymphatic tissue in the body. So this is the common age range, around 6 years, less than 6 years. And secondary infection from the drainage area of the retropharyngeal lymph nodes. What are the drainage areas? It can be from the nasopharynx as a complication of nasopharyngitis, or any kind of sinus infection, or any kind of teeth infection, or infection from the adjoining bones like maxilla. So what happens? First, there is a abscess in the retropharyngeal lymph nodes leading to cellulitis. The whole retropharyngeal space becomes involved, swollen and infected. The whole thing becomes like an abscess. You have seen in the picture. It can be due to, very peculiarly, can be due to penetrating injury. The child is holding a pencil in his mouth with a sharp end inside and he falls on his face. Then penetrating injury, that can cause retropharyngeal abscess. It can occur due to viral upper respiratory tract infection. There will be high fever, very much toxicity, difficulty swallowing, drooling. These are the points you will note in the child and the diagnosis is made. There is reduced neck motility because there is spasm of the muscles which lie anterior to the cervical spine, because they are very close together. They go into spasm and the child cannot move the neck. Retropharyngeal mass, you have seen in the picture, cervical lymph nodes are usually enlarged. X-ray lateral view, that shows prevertebral soft tissue increase. Increase in the prevertebral soft tissue, that is the X-ray finding. And CT scan usually confirms the diagnosis. Okay, then anaphylaxis, or otherwise called angioneurotic edema, can occur as an allergy to food or drug or vaccines. It's an acute emergency in medicine. There may be previous history of allergy. It is usually associated with nasal congestion, sneezing, itching eyes, urticaria, hoarseness of voice, and wheeze. Can be life-threatening if not treated immediately with corticosteroid and injection adrenaline or epinephrine. Next cause, acute laryngeal diphtheria. Usually the child is unimmunized. Age range is 1 to 5 years. But because at this age range the children are usually getting immunized, so there is a shifting of age of diphtheria in the later years. That means the adolescent and post-adolescent age. Now, history of contact may be there with a disease or a carrier. That happens due to exotoxin, Corynebacterium diphtheria. A few are exotoxin producing strains are there. So, those strains will cause this laryngeal diphtheria. Usually that is associated with tonsillar diphtheria. We shall see the picture. There is a patch on the tonsil, and that is called pseudomembrane. If you remove it with the tip of your tongue spatula, then it bleeds. Okay. Now there is moderate fever and serosanguinous nasal discharge from the nose. Red swelling with pseudomembrane on tonsil or pharynx or uvula, and laryngeal involvement causes brassy cough. Usually there are laryngeal involvement, we shall see later on also. In croup also you will get the brassy cough, like a spoon is striking a pot which is made of brass. Tong tong kore awaaz hobe, that is the brassy cough, or sometimes called barking cough. Kukurer daker moto, barking cough. Okay. There will be distress and there will be obstruction. Other complications like myocarditis, neuritis and nephritis may be there due to the exotoxin. Next. Acute bacterial tracheitis. See, this is the typical X-ray. This is the trachea. On the anterior wall of the trachea, there is a small irregularity. That is acute bacterial tracheitis. Usually the age is below 3 years, and usually secondary infection after viral croup. This happens to be starting with a viral croup, and after a few days the purulent secretions are there, severe cough, and X-ray neck, you get this picture. Diagnosis usually done by bronchoscopy. You get purulent tracheal secretions. Next is acute epiglottitis. This is one of the separate subjects given for today. Acute epiglottitis, that is, remember, this is a medical emergency, but nowadays with the advent of H influenza vaccination, this has become extremely rare nowadays. Okay. The agent is Haemophilus influenza or H influenza, commonly called type B. Now it is rarer. Other agents may be there like Streptococcus pyogenes, Streptococcus pneumoniae, non-typable H influenza, staphylovirus like herpes simplex, or even COVID-19. The host may be immunocompromised. Then fungus and Pseudomonas, they are the common organisms. How it spreads? It spreads by droplet from patient or a carrier. The child gets infected. Viral co-infection may play a role, reducing the local immunity. And after colonization, first of all, the nasopharynx is colonized. Usually, peculiarly, the infection is blood-borne, but sometimes it can happen as a direct infection to the epiglottis. That is why in very high percentage of case of acute epiglottitis, you get blood culture positive. So what happens? We are seeing the etiopathogenesis. There is cellulitis and edema of the epiglottis, as well as the aryepiglottic fold, the vallicula. Usually the supraglottic part is involved. That is the difference with the croup. Here the supraglottic part of the upper airway is involved, and in the croup usually the subglottic part is involved. Sparing of the subglottic structures. Now this is what the epiglottis looks like on examination, direct examination of throat. There is mucosal ulceration and submucous gland involvement. There is abscess formation, microabscess formation. The epiglottis is cherry red and edematous, and it is displaced posteriorly. And whenever the epiglottis is displaced posteriorly, there is high chance that it will obstruct the laryngeal inlet. So laryngeal opening has got high chance of obstruction. Clinical features, usually age range is 2 to 7 years, but now it is reduced. We know there is short history, very short history. For H. influenzae epiglottis, you will not get any time. It's very short history, rapidly progressive. There is drooling, there is hoarseness, and patient has got a typical posture of sitting up. The patient will be seen sitting up, hyperextension of the neck, and respiratory distress. This is called tripod position, leaning forward with chin up and mouth open, bracing on arms. বিছানাতে শুয়ে থাকবে উপর হয়ে এই মাথা তুলে এবং like this. This is the typical position for epiglottitis. Cyanosis coma may be there if severe. Stridor is a late finding. That is very important thing about the epiglottitis is that typical barking cough, which is present in croup, this is not there in epiglottitis, but stridor is also not there. If you get stridor, then you know the disease has advanced very severely. Next you see the X-ray. So this is the epiglottis in case of epiglottitis. That is called thumb sign. Thumb sign. বুড়ো আঙ্গুলের মতো দেখতে লাগে। আমরা আগে দেখেছি, আগের X-rayতে দেখেছো what the epiglottis looks like normally. It's like a little finger. But there, you know, it is grossly thickened like a thumb. So sudden onset of severe obstruction, emotional upset or crying may precipitate respiratory arrest. So in case এই পেশেন্টকে ঘাঁটিও না, সোজা কথা হচ্ছে যে don't irritate the child of epiglottitis. He will go into severe laryngospasm. There also you see the thick epiglottis. But X-ray is not the mode of diagnosis of epiglottis. This is just for your interest. I am showing this. Okay. Now general management, how to manage a case of epiglottitis? Treat the case as a pediatric and airway emergency. Usually we intubate. You must not agitate the patient. Continue monitoring of the vitals and signs of upper airway obstruction. Allow the patient his most comfortable position, humidified oxygen, but without irritating the child. That should be given by the time you get to ICU. Okay. And treating team must be on high alert because intubation will have to be attempted. It can be a difficult intubation. So tracheostomy set, you have to keep in your hand ready. So intubation usually is required. Routine intubation is indicated. If you do not intubate a case of acute epiglottitis due to suspected H. influenzae, the mortality rate rises to 15–20%. And if you intubate, the mortality rate goes down to 4 or 5%. So it's most of the pulmonologists or most of the the intensivists in pediatric practice, they do intubate a case of acute epiglottitis. Potentially this is difficult. Always you use one size smaller tube. You have to decide the caliber of the tube according to the height of the child, and one size smaller will be the ideal for your epiglottitis patient. So monitored condition, operating room, monitoring vitals always. Do not force the patient into supine condition. That will cause deterioration. And after management, don't push the patient out of ICU. Keep the patient, keep the child in ICU. You should monitor. Extubation only to be done when by repeat laryngoscopy you have seen that the epiglottis has reduced in size and there is a cough leak test because you have used one size smaller tube and the epiglottis is swollen. So whenever the epiglottis becomes normal, the air leaks from the sides of the tube. That is a cough leak test, and that's a sign that you can extubate. The child is improving. So few more things about epiglottitis. Antibiotics, you have to start empiric antibiotic. You don't have the culture report right then, but you start with either ceftriaxone you can give, the dose given, or cefotaxime or cefepime, all injectables, and meropenem. These are the choices. Do culture of the blood and from the epiglottic surface. Whenever you are doing intubation, take a swab from the epiglottic surface and send it for a culture. Exclude meningitis because many of the patients have got meningitis also, can be a complication. And in case of meningitis, you have to alter the doses of antibiotic. That is why I am stressing upon it. Now change the antibiotic after you get CS report, culture sensitivity report, you get after 2 or 3 days, then you can change your antibiotic accordingly. For the household contacts of H. influenzae epiglottitis, you have to give rifampicin in the dose if it is less than 4 years child. Next we come to croup or acute Laryngomalacia. Usually the virus is the commonest and parainfluenza is the commonest agent. Droplet contract or spread by droplets. Pathology, infection of larynx, trachea and bronchi. The pathological features are inflammation, usually no abscess formation because it's a virus, and along with that there is narrowing of the subglottic area. The mucous glands which are abundant in that area, they do secretion. In the subepithelial layer, there is vascular congestion, there is edema and spasmogenic features, the uh, smooth muscles of the airway, they do contraction. So there is glottic and subglottic contraction, but not supraglottic contraction, just opposite to epiglottitis. So there is stridor, there is suprasternal suction, and as the obstruction worsens, we get indrawing of the lower chest wall, we get respiratory failure and hypoxia, and extension of the, when the infection extends to the bronchi, then on clinical examination we find wheeze and crackles, along with that air trapping. Why the air trapping? Because the air is moving in, it cannot go out. From that picture, I have shown you, this is the air trapping, okay? Prognosis, good, because only 5% of the patients, they are hospitalized. 85% they have mild croup, and severe croup is very rare. Very low mortality, complications can be there, pneumonia, pulmonary edema and acute bacterial tracheitis. They are the usual complications. So clinical features, we know for the first 1 or 2 days there is fever and coryza and cough and sore throat. Next 2-3 days there are features of upper airway obstruction. Mostly it goes away within 7 days. Few cases there is severe airway obstruction, there is harsh stridor, there is barking cough. Barking cough is the hallmark of this thing's croup. Intercostal suction will be there will be tachypnea, there will be irritability, there can be lethargy and cyanosis, and in those cases they may need hospitalization, but usually not. Differential diagnosis usual, you get a case of croup, remember epiglottitis, remember bacterial tracheitis, foreign body, laryngeal diphtheria, because the treatment will be absolutely different. Now, cause of airway obstruction in this case is, remember this is subglottic inflammation. X-ray chest, that causes the Steeple sign, I will show you. Steeple means upper part of a church, upper part of a church goes like this, and this is the Steeple sign. The airway is narrow there, and the margins of the airway, they do look like steeple of a church. This is called Steeple sign, and if you see on the lateral view, there will be narrowing of the subglottic area of the trachea, along with that hypopharynx will be distended. Ektu tule now. So management, our goal is to reduce the airway obstruction. Majority can be managed at home. First, assess the patient, hospitalize if indicated. Exclude other differential diagnosis we have seen. Supplemental moist oxygen or heliox means helium and oxygen mixture that changes the turbulent flow into a streamlined flow. That is what is said. Airway, breathing, circulation, they should be maintained. Avoid agitating the patient. Corticosteroids, dexamethasone in the dose given. It can be given IM or it can be given IV. Stat followed by this dose 8-hourly for 1 to 2 days. Now this is other managements, alternative to dexamethasone, you can go for budesonide nebulization, or oral prednisolone you can go for, depending on the severity of the case. Nebulized epinephrine, there is one of the treatment modalities, they reduce the edema by reducing vasodilatation. Discharge the patient if symptomatically better after 3 hours after the last epinephrine you have given. Intubation only in minority of cases, antibiotic only if you see there is chance of bacterial superinfection, otherwise no antibiotic. Now chronic stridor, that is Laryngomalacia. Laryngomalacia is a disease of infancy, usually starts within 2 weeks of birth, and what happens, the larynx is soft and flabby, and it can usually disappears by say 1 to 1.5 years. continue to increase in severity up to 6 months. If the child is well-being, if the child is gaining weight normally, taking feed normally, then you need not do anything excepting assuring the parents. Okay. The inspiratory or low-pitched stridor is there. The stridor is inspiratory and it is low-pitched, and that is exacerbated by exertion. That means when the child is feeding, when the child is crying. Diagnosis is based on symptoms. Investigations done only if the child has got feeding difficulties or work of breathing is very severe, or there is wet respiratory sound, or there is recurrent respiratory tract infection. What is the diagnosis of choice? Is flexible laryngoscopy. You can show the collapsing laryngeal wall. Bronchoscopy is done only for coexisting airway anomaly if suspected. Before go to foreign body aspiration, you see the stridor. This is the algorithm of stridor. A patient comes to you. You see whether this is acute or this is chronic. This is just in a nutshell. This is either acute or chronic. If it is acute, then see whether there is life-threatening or this is not life-threatening. If life-threatening, you think of those things: respiratory failure due to any cause, or angioedema, or foreign body, tonsillitis, any abscess like retropharyngeal, parapharyngeal, or peritonsillar, and epiglottitis. And if it is not life-threatening, there is no fever or upper respiratory infection, immediately think about foreign body, you think about hypocalcemia, you think about angioneurotic edema, you think about neurogenic causes. If it is a low-grade fever with upper respiratory infection, you think about croup, you think about diphtheria. If it is high fever with upper respiratory infection, you think about epiglottitis, you think about the abscess, and you think about bacterial tracheitis. Now, foreign body aspiration, very important subject. This is one of the long questions for you. Now, what are the types of foreign body aspiration? You know what is the common age? The common age is 1 to 3, 4 years. The toddlers, they go about, explore things and put it in their mouth, or sometimes some elder brother or elder child is there in the family who puts something into the mouth. So, it can be, what are the types? It can be organic, it can be inorganic, it can be radio-opaque, it can be non-radio-opaque. That means you can see the foreign body on X-ray or not. According to site of lodging, it can be right lung most of the cases, most of them in bronchus intermedius, in the middle bronchus. The rest of the cases you will find in the left lung, in the trachea, in the larynx, or rarely bilateral. So, this is categorization according to the origin, according to the type or according to the site of lodging. Clinical presentation, the patient can present immediately with severe respiratory distress, or it can be asymptomatic. It depends on a stage of presentation and the site of block. Site of block, upper, immediate presentation, you can get immediately few minutes after the child has aspirated. Okay, then. Utia now. Clinical presentation, there are 3 stages of symptoms. Initial event is their paroxysm of coughing, kashbe, choking hobe, obstruction hobe. Outcome can be either complete obstruction leading to death, or the child can expel the object, expulsion hoye jete pare, or next possibility the child can go into chronic stage, that is the asymptomatic interval. That is the second presentation. The foreign body is already lodged there, the reflexes are already becoming fatigued, so irritation becoming less, symptoms becoming less. And third stage is the stage of complication. There is obstruction, maybe due to complication due to obstruction, complication due to erosion. Any hard foreign body with sharp objects can do erosion. Infection, because there is a stasis, and the presentation can be with fever, it can be cough, it can be hemoptysis, it can be pneumonia, it can be atelectasis, that means collapse. One full bronchus is obstructed, so the lung will collapse gradually, and there can be presentation with a lung abscess or bronchiectasis. So, classic triad of foreign body aspiration is told to be cough, localized wheeze, and decreased breath sound. ঠিক যেখানে লজ করেছে সেখানে তুমি ব্রেথ সাউন্ড কম পাচ্ছ, সেখানেই তুমি হুইজ পাচ্ছ, and the child is coming to you with cough. This is the classic triad, but very rarely found in your clinic. Now, according to site, foreign body, If it is in the central airway, it will cause episode of choking with dyspnea and hoarseness and dysphagia. If it is a large bronchi, then it will come with a cough, with wheeze, with dyspnea, cyanosis, and decreased breath sound, as I have told already. If it is a lower down airway, nothing excepting fever, recurrent fever, and chest infiltrates on X-ray, which are not resolving. তুমি antibiotic দিলে after 3 weeks, after 4 weeks, once again you are doing X-ray, the symptoms persisting. It's the same position, opacity. That's a sign of acute foreign body aspiration. Now, management of foreign body aspiration you can get in the acute stage, that is in the choking episode. Now, the management depends on the age of the child. If the child is above 1 year of age, whatever it is, you first assess for severity, whether it is mild or it is severe. If it is mild, then encourage coughing and monitor. অনেক সময় বাচ্চাটা কেশে বার করে দেয়, কাজেই তাকে ডিস্টার্ব করো না। If the child can speak, if the child can cry, if the child can indicate that something is there, then you mean the child is, it's not in a severe stage, then you can wait. But if it is severe, that the child cannot speak, cannot cry, then look for the response. Look at the higher function, where the child is unconscious or lethargic. If the patient is responsive, then there is a maneuver called Heimlich maneuver. We shall see. This is the Heimlich maneuver. Look there. The left fist is on the, in between the sternum and the umbilicus, in the epigastric region. The left fist, like this. You are putting the right fist over there. Look, you are putting the right fist over there, and you are giving sudden thrust. That expels the foreign body. 1, 2, 3 times you give thrust. Usually that works. So this is called Heimlich maneuver. This is for above 1 year. Below 1 year, you should not give any Heimlich maneuver because that will cause damage to the viscera. Now, if the child is unresponsive, what you do? Lower him to the ground, supine, and give CPR. CPR means cardiopulmonary resuscitation, chest compressions. You give 30 compressions like this at the speed of 100 to 120 per minute. মিনিটে 100 থেকে 120টা করে কম্প্রেশন করো এবং প্রত্যেকটা 30 কম্প্রেশনের পরে after every 30 compression you look at the oral cavity, look inside the oral cavity whether this has come out or not. If seen, then you can take it out manually, but never any blind exploring. না দেখে আঙুল দিয়ে ওটাকে বার করার চেষ্টা করবে না, because if it is there it can go further inside, right? Now, what if the child is উঠিয়ে নাও? Now, what if the child is below 1 year of age? Then no abdominal thrust. Remember, no abdominal thrust. You assess for severity, whether this is mild or severe. If mild, then keep the child on the caregiver's shoulder, মায়ের কাঁধে এইভাবে থাকবে, and monitor whether the child is deteriorating or not. Look for attempts for cough, look for the voice, and look whether there is any cyanosis or not. Now, if severe, that is the unable to speak or unable to cry, unable to cough, then look for response, whether the patient is responsive or not. If responsive, then this maneuver. This is called back slap and chest compress. Back slap, chest compression. This is how you keep the baby on your knee, holding the baby with one hand, and you slap the baby on the back with the other hand. And 5 there, and you then turn the baby around in a supine position like this. Remember, the head will be in a slight lower down position than the chest. বুকের থেকে মাথা নিচে পজিশনে থাকবে. It will lower down so that the foreign body comes out. And 5 there, chest compression. So back slap and chest compression or chest thrust. Now, keeping the head lower than the chest, that is the way if the child is responsive. And if the infant is unresponsive, then once again you put him on a flat surface, start chest compression and CPR, and you see inside the mouth. If it is there, then take it out, otherwise. And along with that, keep your emergency response team ready. You make your emergency response team ready. If necessary, they will do the what? They will do bronchoscopy. Usually rigid bronchoscopy is favored, because with the rigid bronchoscope you can take out the foreign body as well. And if the child, of course, presents in a late presentation, presents late, then also treatment of choice is bronchoscopy and take out the foreign body. Remember, in case of foreign body, no history of infection, no history of upper respiratory symptoms, and sudden onset. Sudden, and it is said it is a dramatic onset. That is the way you diagnose a foreign body. Okay. This is I think you have got access to the the software. প্রিয়াঙ্কা ওটা যাতে আসে, ওটা যাতে ইমেলটা রিসিভড হয় এটা দেখবে। এইটা হচ্ছে তোমাদের ফর লং কোশ্চেন, ফর অ্যান্সারিং লং কোশ্চেন্স ইন দ্য এক্সাম, how to diagnose and how to manage a case of croup, probable long question. And this is a algorithm taken from a book of pediatric pulmonology. You just take it down, take the soft copy or hard copy as you please, then you read it and prepare your answer for your exam. Okay? So that's it. Thank you for the patient hearing. This is also another thing, এটাও একটা short form algorithm. তোমরা এই ছবি নিয়ে নিতে পারো, I think that can help you also.